Good morning. My name is Francine Poole, and I'd like to introduce my group members, Ginger Fontenot, Sarah Girlinghouse, and Stacy Hackler. We did a concept analysis on compassion fatigue in nursing. The background and significance of compassion fatigue is it describes a phenomenon of nurses losing their nurturing ability towards their patients. Secondary traumatic stress disorder is a friendlier term used for compassion fatigue, and it was coined by Figley. Patient connection is altered and has a negative impact on the caregiver and the client, which affects the care that is given. Meaning in published works, the theoretical model is based on key elements of empathetic ability, empathetic response, and residual compassion. Compassion fatigue evolves from compassion discomfort to compassion stress, and finally to compassion fatigue, where the energy extended by the caregiver surpasses their ability to recover from it. It is also an offshoot of the word burnout, according to Sabo. Compassion fatigue is a cumulative, progressive process, and it manifests in a calamitous way, which is harmful for the nursing profession, which requires caring and compassionate nurses as its basis.
Hi, my name is Ginger Fontenot, and I'm going to talk about the purpose of a concept analysis. The purpose is to break down the elements of a concept and to examine each aspect within that given concept. It takes vague terms, and they're clarified so that one can fully understand, and it also encourages a standardized language for nurses to use. The purpose of concept analysis for compassion fatigue allows us to identify the concept within the nursing workforce, to fully understand the meaning of the terms of compassion fatigue, what the symptoms will consist of, and how the symptoms can be identified. The definition of compassion fatigue is the cumulative result of prolonged, intense interactions with the patient, the use of oneself, and exposure to stress. The attributes of compassion fatigue consist of the physical effects, which are burnout, absence of energy, and accident proneness. The emotional effects are breakdown, apathy, and the desire to quit. The social effects are unresponsiveness, callousness, and indifference towards patients. The spiritual effects of compassion fatigue are poor judgment and disinterest. And the intellectual effects are disorderliness, boredom, weakening attention, and impaired ability to concentrate. I want to talk a little bit about the theoretical definition of compassion fatigue. In 1992, Joynson first defined it as the ability or loss of ability to nurture. And she defined this with emergency room nurses. And in 1995, Figley further defined the aspect of compassion fatigue as the consequence of behaviors and emotions from knowing about a traumatizing event by a significant other, the stress resulting from helping or wanting to help a traumatized or suffering person. It is an evolving process from compassion discomfort to compassion stress, and finally results in compassion fatigue. It is where one's restorative process has been surpassed.
Hi, I'm Stacy Hackler, and we have examined the basic elements of the concept of compassion fatigue. Now we want to look at the methods for testing the criteria by looking at different types of cases. We'll be looking at the model case, a related case, a borderline case, a contrary case, and an invented case. The model case, as defined by Chin and Kramer, is the description of a concept that satisfies this statement. If this is not X, and in our concept it would be compassion fatigue, then nothing is. And with the following is a case that we developed that we feel is a model case. Susan has worked as the charge nurse of an 8-bed inpatient hospice unit for 5 years. The unit is at capacity 80% of the time with terminally ill, imminently dying patients. To achieve comfort for these patients, Susan must administer opioids and benzodiazepines intravenously in titrating doses. This requires constant use of Susan's pharmacological skills and assessment skills to monitor the effectiveness of the medications and to balance the desired effect of the medications with untoward side effects. The families of these patients are allowed to remain with their loved ones 24/7. Susan is called upon multiple times daily to explain end-of-life issues to families who need a large amount of emotional support. Death is a daily occurrence, and it is not uncommon for there to be multiple deaths in one day. Susan repeatedly gives of herself to comfort distraught family members. Susan used to love her work as a hospice nurse and felt that hospice nursing was her calling. Her patients and families respected her. Currently, Susan feels she's going through the motions and senses a decrease in enjoyment of her usual life activities. She also has a don't-care attitude about the work she used to love. Her family is noticing changes in her functioning on all levels, from personal to spiritual. Susan is experiencing compassion fatigue. This scenario is an example of a model case because it meets all of the defining characteristics as identified by Coetzee and Klopper. Susan has used up her compassionate energy without proper time to rest and be able to restore that energy so that recovery of that injury is no longer available.
Good morning. I'm Sarah Girlinghouse, and I'm going to present the related case. Per Walker and Avant, a related case is defined as a case that resembles and relates to compassion fatigue, but ultimately is a different concept, such as coping would be. The example that we presented was Michelle, a staff floor nurse on a busy med-surg floor, arrived to morning shift report to find her previous day's patients had been redistributed and an entire new caseload had been assigned to her. At first, Michelle was angry and frustrated with her job, and she stepped back, took a deep breath, told herself that everything would be all right. She puts a half-hearted smile on her face and finds her night nurse for report. Michelle has demonstrated a related concept to compassion fatigue, noted as coping.
Chin and Kramer defined borderline case as an instance of metaphoric or pseudo-applications of the word. Thus, same word, different context on our slide. Keying on the word fatigue, listen to the following scenario. Jill is an RN who has worked in the newborn nursery for 6 years. She's growing tired of the same routine night after night of taking care of newborns. She feels she's experiencing compassion fatigue because she's bored with her tedious work. Jill is not experiencing compassion fatigue. She is rather bored of her work, which is a completely different thing than the compassion fatigue that we've talked about earlier, and it also does not meet the definition of compassion fatigue as we stated earlier, where compassionate energy has been expended without adequate rest to restore that energy, resulting in the loss of the ability to recover that energy.
The next case is a contrary case. Walker and Avant define a contrary case as the instances of a concept may be alike in some areas, but easily recognizable as a different to the original concept. Our example of this contrary case would be Claire, a staff nurse from the medical surgical floor, arrives for her 4th day shift in a row. This is an overtime day for her to help the scheduling out of a bind. Upon arrival, she finds that instead of having her same team of patients, the charge nurse has had to redistribute them due to the LPN to RN ratio that day. She refuses to accept her assignment and makes a scene in the unit manager's office. She returns to the floor for her shift only after giving her 2-week notice to the manager. This is clearly not a case of compassion fatigue and meets requirements for a contrary case, as outlined earlier by Walker and Avant. In the above scenario, the nurse is angry at the situation and reacts to the anger. She may be experiencing fatigue, but not compassion fatigue.
Walker and Avant identify an invented case as a case that contains ideas outside of our own experience, almost like science fiction. The following case will describe an invented case. Jim is a family nurse practitioner in a long-term care facility which houses 500 residents. He daily makes rounds on residents with medical needs as reported by the staff nurses. Jim sees 40 to 50 residents a day. Each morning when Jim arrives to the facility, he goes to the corner of his office, curls up in the fetal position, and sucks his thumb for 5 minutes. During this time, the ghost of his deceased mother appears to him and reassures him that he is a good boy and is competent to complete the daily task before him. Obviously, Jim is deeply disturbed and past the point of compassion fatigue.
I'm going to talk about the antecedents of compassion fatigue. They include risk factors and causes. The risk factors are contact with patients, the use of self, and stress. The causes of compassion fatigue include exposure to the mentioned risk factors that are prolonged, continuous, and very intense. The consequences of compassion fatigue have a progressive pattern. They start with compassion discomfort. If not resolved, will result in compassion stress, and finally will result in compassion fatigue. They consist of physical, social, emotional, spiritual, and intellectual effects.
The study by Coetzee and Klopper done in 2010 described the empirical indicators of compassion fatigue. It is a progressive and cumulative process which starts off with compassion discomfort, which leads to compassion stress, and ultimately the end is compassion fatigue. The empirical indicators address physical, emotional, social, intellectual, and spiritual aspects of compassion fatigue. The risk factors are the amount of time spent with the patient, which is usually a prolonged period of time, the use of self, which is continuous, and the amount of stress, which is normally very intense. The operational definition of compassion fatigue is that it is a result of progressive, cumulative, and evolving processes, which begins as compassion discomfort, progresses to compassion stress with prolonged patient contact, use of self, and stress exposure. In summary, compassion fatigue is a progressive, cumulative process that affects caregivers exposed to repeated, prolonged contact with patients experiencing a traumatic life event. Nurses and caregivers who are most at risk to develop this are those who work in stress-related environments, such as intensive care units, mental health workers, pediatrics, and oncology units. It is also considered an occupational stress, and caregivers who are continually exposed and are at risk for compassion fatigue, they need to learn more ways to care for themselves and to nurture their own selves in order to prevent the effects of compassion fatigue. We find it very difficult whenever we're in a nursing environment to give to ourselves, but self-care activities for caregivers to combat compassion fatigue includes work-life balance, exercise, diet, attention to pleasurable non-work-related activities, and meditation. Further studies do need to be conducted in order to determine if recovery from compassion fatigue is at all possible. Thank you.